name is Dr. Honorine. I am Rwandese and I am currently in Rwanda. I am currently working as a clinical engagement specialist at the Rwanda Medical Supply. This is the company that is in charge of supplying medicines and also other consumable health products in Rwanda. So, when Dr. Eric asked me to talk about equity, access in global surgery, the first thing that came to my mind, of course, is to talk about the field that I am in and how it relates with global surgery. Of course, I have thought of something that will align with, and definitely we will learn a thing or two. So I want all of us to imagine. Let's not think about Uganda. Uganda is a replicate of Kenya, of Tanzania, of Rwanda, of Burundi, of Sudan, South Sudan, all of these low middle income countries. Where we have okay, I'm sure that's how Uganda is, where we'll have levels in the healthcare from top to down, from referrals, we go to regional hospitals, level 2 teaching hospitals. Then again, we go to health centers and, of course, health posts. As we know, we have a problem and an equity gap in our systems as a low middle income country, where we have different products, different medical supplies, especially the surgical supplies that are allowed at each level. I'll give an example of Rwanda. Rwanda, we define it as that we provide surgical care regardless of location or income. So the patient has to get safe, timely, and affordable surgical care. In Rwanda, in public hospitals, when a patient comes, they don't ask for money. I'm talking about, let's say, a patient who needs emergency surgery. We do not require for them to have an insurance, for them to have some money on themselves. We require them to just come to the hospital and we treat them. After treatment, that's when other things can be discussed. But mind you, this is at any hospital, and any hospital will just offer what it can. So I want us to take, because we have referrals, as I mentioned, the surgical supplies that will be in a referral hospital are not the surgical supplies that are in a district hospital. I hope we all agree. So when we have a district hospital and a patient is near the district hospital, the patient, if they go through an accident, or let's talk about a case of a woman with obstructed labor. So if the case can be managed at the district hospital, we say that in Rwanda, every patient will reach there within 2 hours and will be helped. We are okay with that. And at the referral hospital, if a patient is also nearby and they get an obstructed labor, they can be helped within 2 hours, hence saving the mother and the baby. So let's imagine in a district hospital where a patient comes, but since the surgery they require is not provided at this hospital, even the materials, the supplies are not there, we have to refer them. We all know in our countries how referring a patient, you have to first call to see if we have a bed, and then we have to see if there is a doctor who will operate. We have to call and see if we have an available ambulance. All the shenanigans that comes with our hospitals. So all that time, it takes more than 2 hours. And if it is a case of obstructed labor, of course, complications start coming in, and we fear even the loss of the baby or the mother. So there is now that inequity that is there. There is a gap in the access to the surgeries. I hope we are all together. If anybody has a question, please raise your hand and we will answer it as we present. So For a person who is near the referral hospital, there won't be any gap. They will receive surgery that is timely, that is safe, and that is affordable to them. But for somebody who has to wait to be transferred, and if there is any complications, then there is no equity there. And that brings me to why do we have, it's called the last mile, why do we have that gap, and how can we look for the solutions about it? So we've made progress on training surgeons and of course building the ORs, but the last mile of surgical equity is consumables. We agree with that. Sometimes you go to a district hospital where we've made efforts to bring doctors, to bring surgeons. But when we ask them, they say that we do not perform this surgery simply because we do not receive the supplies that can or the kits that can perform this surgery, because we still have levels in the health system. So if it is the referral, they're the ones who are allowed to use some, let's say, some orthopedic kit, which is not taken to the district hospital. So there is a gap there in the consumables, which we should, of course, address. And as a clinical engagement specialist, I hear this daily. We can do this surgery, but we do not have the supplies. We can do this, but we do not have the logistics. So the gap is in the demand demanded by these other hospitals but not provided. How can we empower surgeons at district hospitals that are near the population to be able to perform these surgeries? For example, you'll find we know that we can, let's say orthopedics is a common department in surgery, but there are some surgeries in orthopedics that can be performed only when you're referred. You come, they stabilize you, they put you on traction, but they have to refer you. I don't know if that happens in Uganda, but in Rwanda, you find that hospitals have like a lot of patients who are on traction, and they're like, the femur has developed callus, and that means when they go to operate them, they'll have to shave the bones first. So, what can we do to empower the surgeons to be able to perform these surgeries? And also, what can we do to supply these materials to the district hospitals? I'll give you a short story. So when I started the job that I'm currently doing, I was, of course, the things that I look at is the gloves. I look at their syringes, proper sizes. I look at the sutures. Does every surgeon have the suture they need to use? They asked me to make a list of sutures that I would need to make sure that surgeries are being performed well, on time, and of course, giving us good results, the best results. I remember making a list, and my conclusion reached over 200 sutures. There are numbers, there are specifications. We'll have like a number 3, the one that is curved, the one that is sharp ended, the one that is blunt handed. So there was all that. And we found that as low middle income countries, sometimes we cannot afford all the types of sutures. And we find our surgeons may use different, the same sizes or the same sutures for things that should be operated differently. So these are challenges that we still face as poor countries, but also these are challenges that we can bring solutions to when we agree, even as medical practitioners, to agree on what sutures to use. So we demand driven forecasting for the hospitals. We are the advocates. As the moderator mentioned, I am a global surgery advocate. I have completed my fellowship in a global surgery advocacy program, where we found that it doesn't matter who brings the change. What matters is that the change has come. You as a medical student, you as a first year medical student can bring a change in our surgical department. Simply because you've gone to the OR, you found that the senior doesn't have sutures, you don't have to keep quiet. That's why you start using your social medias. Tweet about it. Go to LinkedIn. Talk about it. Somebody may reach out to you, somebody in the global health, somebody who wants to do that project. Okay, so we can all bring a change. And that's the mind I am with at the supply chain in Rwanda, where I encourage, where I advocate, where I have to fight for materials in surgery to be provided. And then we have to keep in mind that every OR, whether district or referral, needs a minimum surgical package. So that when we say that we guarantee equity, I want that a patient who is in Gulu, a patient who is in Karale, a patient who is in Kampala, where Mulago is located, all of them should have equity in surgery, should be able to access the same surgery. And the thing we could do, the thing we could advocate for, is to make sure that the supplies are taken to each hospital. Because if a surgeon is at a hospital, just a surgeon, then it's not enough. They need a kit, and we should have the minimum package. And then we should have a clinician voice in procurement. Another little story. Of course, we did medicine as our bachelor's, and then after, I remember walking into UGHE. All I wanted to be was a surgeon. But throughout the year, they showed us that you don't have to be the surgeon to talk about surgery. You actually have to be interested in that. You can go in line with either global health, we have health financing, we have health informatics. You can go in those lines so that you're able to sit at spaces where they procure, where they make all the budgets. So it's something that I've learned. Right now, my voice, my clinical voice, my surgical voice is at all these big tables because I am able to understand that for me to talk about surgery, I do not have to be a surgeon. I do not have to be there as a senior. I was operating, but I have seen the inequity in surgery, so I can go and talk. So, the voice of a clinician, we have a professor, Professor Barnabas, who says that if you think you're too small to talk, then try sleeping with a mosquito. As small as a mosquito is, it denies you peace. So as small as we are as medical students, as doctors, as future surgeons, we should know that our voices are not less. But where are we presenting these voices? Are we going to the Ministry of Health? Are we using it in our lecture rooms? Am I going into these actual procurement programs? So the voice is something important. As my closing remark, I would say that equity in global surgery won't be won only in operating rooms. It will be won in warehouses, where I am right now. It will be won in delivery trucks. It will be won in procurement meetings. It will be won in insurance rooms because safe surgery starts long before the first incision. It starts with the supply, when the supplies arrive. It starts when the surgeon comes in, and it starts when I and you start speaking. Thank you so much. That is it.
Wow, wow, wow. Thank you so much, Dr. Honorine, for those remarks. I feel I have really gotten a lot. I am into understanding equity and accessibility very well. And it has really been a wonderful and nice session. And at this point in time, I'm sure I'm not the only one who has been touched. I'm very sure that a lot of people might have questions regarding the session, regarding equity, regarding um, accessibility as well. So at this point, I would like to open the mic to anyone who has a question regarding equity and access to global surgery. Doctor is still with us. We can still she can still answer those questions. If you're shy to open up your mic, please, the chat box is still also open. We can also have questions therein. Thank you so much. Guys, feel free to raise up your hands and ask questions. You can give also your comments about the session, or you can give your experiences that you've had with surgical care as well as equity and the challenges that you might have faced at one way or the other. We are here to share ideas as well, because it has been mentioned at every level you are in, you can create impact, your voice can be heard. So let's start now. Let's start sharing ideas, asking questions. Yes, Dr. Felix, I see your hand is up.
Yes, good evening, everyone. Yes, apologies for the prayer session had kind of moved out. So I want to thank Dr. Honorine for the insightful session. Thank you so much. It has been so informative and surely I've learned a lot. So my question is, like, from your experience in this field, what is currently the most overlooked systemic barrier in what is the most currently underlooked systemic barrier in surgical access in our region? And how can us local advocacy campaigns better address it? Thank you.
Thank you so much, Felix. While you're asking the question, I feel like a lot of things lined up in my mind, and I don't know what to put in front. But I would say that, as you said, I will quote you, the local advocates. What can we do? The best thing we can do as local advocates, as medical students, is actually encouraging patients to acquire or to actually look for access to surgery. We live in villages where our parents themselves, our sisters and brothers that we live with, complain of things. And as medical students, we already have a sense that that might be a surgical disease, right? Let's say you have somebody in your house, in our village, who suffers from a diabetic foot. They know they got diabetes. They do not go for their medications, refills, and they started to have a diabetic foot. But what we do is we tell them, and no, we will sit and be like, oh, you should go to the hospital. But we do not actually encourage them that that is a surgical that's the surgical case, and you should go and look for the surgical care. So I think that's one. That's one, and I think it may not be the first, but that's one of the biggest gap that we have. That our patients do not actually come to seek surgical care as early as possible. They just have to wait at home until somebody has an emergency. Let's say they can't walk, they can't breathe, or they're in some state too much pain, and they seek surgical care. The other gap that I see that we can work on as local advocates is actually opening up to our seniors. There are some things that happen in the OR, or let's say a senior says that I will operate one person per day. Yet you know that as a medical student, you've been seeing people in the OPDs that like 10 of them, 15 of them. So it's up to us to actually walk to these surgeons like, hey, sir, we have a long list of patients that are waiting. How about we try to have maybe 5 people or 6 people per day? And that does not come out as rude when we learn from the surgeons on how to do some things. As a medical student, you should be able to ask your seniors, teach me how can I do the biopsy? How can I do the abscesses? So that he knows that these little things, my medical students can do it. And I focus on the big ones. So I think we can be advocates, but we can go to work, especially that in surgery, it's all about action. After we bring the patient and after we have the supplies, after we have the money. So also helping out and also getting to be in discussion with our seniors would help. Thank you.
Doctor, thank you so much for the response, and hopefully, Dr. Felix, you've been answered. I saw another hand up. Dr. Kato, your hand was up. I don't know if you're still on this call. Please unmute and pose your question.
Okay, all right. Thank you so much, Roycelyn, for the opportunity, and a good evening to everyone. My name is Anthony Kato. I just had a question as the session was moving on, and we've, like Dr. Honorine has put it, as medical students, all that can be done is advocacy. So, since we also have young doctors on ground, not as as medical students now, what other opportunities in the field of global surgery can we like try to explore so as to contribute positively on the global perspective? Thank you. That is my question.
Thank you so much, Anthony. Why I can't see the participants, but I saw Sonia here. Sonia, can you have the opportunity to answer that question? Sonia is midwifery student, and she has been in programs of global surgery. You know, you don't have to do global surgery after you graduate, after you've reached a certain level. Even as a student, there are courses for you. There is global surgery advocacy, there's global surgery informatics. You can go learn about many things. Sonia, are you there? Do you want to answer this question?
Hi, Dr. Honorine. Thank you very much for this wonderful and informative session you've had with us. And may I please have a question once again?
So Anthony asked that as a medical student, what opportunities are there for him in global surgery as a medical student?
Okay, thank you, Anthony. I think the opportunities are out there and they are a lot as long as you're committed. Especially I would say you can focus online because the sky is unlimited online. You can have a session or a program from anywhere in this world, and you are just sitting there doing your medical school. For example, I've started my journey with the Global Surgery Advocacy Certificate. I didn't limit myself that I'm not medical student. I'm not into surgery like a lot like surgeons, like doctors. But I remembered that I'm a midwifery student. I also prepare mothers to go to theater, and I see a lot. I help in the theater. Like, I see a lot that I can talk about. It's about advocacy. It's about speaking out on behalf of others. So I didn't limit myself, and I started with the Global Surgery Advocacy Certificate from University of Global Healthy, and I got a foundation from there. I learned a lot, basics of global surgery, history, and everything. And from there, like I felt in love with global surgery. To I like as you see, I'm here because it's about global surgery. I really also wanted to know more and more about global surgery. That's why I applied for this program. And I'm not like right now. I'm not in Uganda, like in Guru or where. I'm in Rwanda, but I got to know this about this opportunity, and uh, I I gave it a chance. I applied, and I got accepted. Still, this is the opportunity, and still I'm looking for other opportunities around the world about global surgery, and I can guarantee you that they are there. You just get commitment. You just know what you want and go for it. Thank you.
Thank you so much, Sonia. And I would want to add something. So I would say that I started global surgery advocacy or doing things about global surgery when I was still a medical student, and this is how I used to do it. I did not do my medical school in Rwanda. So when I came back for my internship, I would see things that shocked me. While I practiced, everybody had money to take care of their medical bills, of their transport, of their food. So things were so okay. But when I reached here, a patient would want to be discharged like day 2 post-op. And even when they're discharged, they would walk from the hospital to their home, which is like 2 hours or 3 hours walk, because they cannot afford a simple boda boda or bicycle, the transport that we use here in Africa. But what I did, of course, I did not, as a medical student, I did not have enough money to go to give all the patients transport. But what I did was going to the social worker of the hospital, since she was receiving money of the well wishers and paying medical bills for the patients, doing things here and there. So I advocated for patients, especially the surgical patients, to receive their transport that takes them, and of course, the transport that will bring them back for their checkup, for their follow up, maybe the first one. So that's what I did, and it worked. The patients that I knew that didn't have a voice, I went to the social, and she always provided transport. And I think that's a very huge contribution to the global surgery space, where I make sure that after performing surgery, the patient is able to come back for the follow-up. So the gaps are a lot. The gaps are a lot, and we are all looking to solve them. But don't go far. Don't think when you get an opportunity to sit with the Minister of Health, that's when you solve it. We've had those opportunities, and you talk to him, and he won't even remember your name in the next 5 minutes. But you can impact just in the Gulu University where you are. Thank you.
Thank you so much, Dr. Honorine, for those remarks. Personally, I have also a question. Getting difficulty in understanding the difference between equity and equality in global surgery. Could you give some light about that? Thank you so much.
So, equity and equality in the dictionary, it's not gonna be any different way we define it in global surgery. As we know, in equality, everyone is given the same chance. But in equity, everyone is given the chance that they need. So, as I said, just the example that I just used, we did not provide transport to every patient that has gone under surgery, that every post-op patient will receive 5,000. No. What we did was that the poor ones that can't afford it are the ones that we gave transport. Now that's equity. If it was equality, everyone should be given 5,000 post-op. But since it's equity, then we give the ones who need. And then for equity access in surgery, we mean that, for example, on the page of affordability, if someone can afford, let's say, for the femur fracture and we know they cannot afford it, the hospital should be able to provide the surgery for free. If we have a patient who needs surgery and they're in Gulu, but the surgery they need is in Kampala, and there is a patient who is in Kampala, you see, they are equal because they are near hospitals, but are they near hospitals that can help them? So we want to create the equity in surgery where everyone will get the surgery that is safe, that is affordable, and that is timely, but according to their needs. Because we cannot, let's say everyone is subject to surgery and we have one OR. But the first one is an obstructed labor, and the second one is a femur fracture. If it is equality, we say that since the femur fracture came earlier, we first do the femur fracture. But with equity, we have to put on the scale and see who needs the surgery more urgently. And that person is going to be the obstructed labor, of course. Thank you.
Yeah, thank you so much for the response. I can now understand the difference. Thank you so much. We're still welcoming questions. If there are any, please raise up your hand and I'll surely pick you. Ask questions for better understanding because I am not the same as I came. So please, if you have any questions, just post them over. You'll get better understanding.
We have a question, I will read it. How do you balance developing your clinical leadership skills with the administrative demands of running regional healthcare initiatives without burning out? And lastly, how do we leverage strategic networking and cross-border partnerships to fund or amplify our local advocacy efforts? So first of all, the burnout is inevitable. Dr. Eric will testify that I am, how will I say, I am vaccinated against burnout because I personally will show up, how will I say, I show up even when I wake up, I'm not subject to burnout. I want stress. Like the way he reached out to me and told me you have to present. I did not go reading books. I did not go stressing, oh my God, at 5 p.m. I have to see students. What I do is that I understand. In my head, I already know that there are very many topics that I need to talk about. So I will go and talk about it that way. So if I put the according to context, if there is, as I said, you guys are just medical students, so you can just do as much as you can do. There are things you cannot change in the hospitals simply because you are not the HOD in surgery, you are not the Minister of Health, so you do what you can do and you change bits by bits because healthcare, global surgery, all these, there are systems that are complicated and that have many what you can and what you like, you have to do what you can and what you're able to do. So that's how I would advise you. You have to sit down and read what you've had today, go develop it and choose a path and see how can I help in global surgery. We've seen our Dr. Eric, I'll quote him many times. He is seeing the gap that most of the medical students, the doctors, the surgeons do not know a lot about global surgery. They are not mentored enough about global surgery. And he has gone in that directions, and that's why all of us are here, so that we can solve and we can fill the gap that he's seeing. So also you have to see a gap and then also go about it and remember that you can just do as much, not everything. So for me, I try to balance life. There is time for school, there is time for advocacy, there is time to take care of myself, which of course solves burnout. There is time to when you meet somebody, you when you meet your classmates, you meet your lecturers, and you're talking about global surgery from morning to the evening, then you burn out. But like, look at people. Who should I talk to? Who is gonna help? Yeah, and that brings me to your second question of, you may say that everybody you meet, you're going to tell them about your project in global surgery. You're gonna seek funds from them. Then go with that. And it takes time. If you're planning to do LinkedIn advocacy, if you're planning to seek for funding opportunities, apply as much as possible. Don't give up, because it's a journey. It's not easy even for us that are up there. But like, what we do is consistency and looking for all this. Thank you.
Thank you so much, Doctor, for the response. Any more questions? Any more questions anyone can ask in relation to today's topic, as we are coming to the top of the hour? Guys, feel free to ask whatever you want to understand about equity and access to global surgery. Something has come to my mind. I'm asking myself, is access only when a patient gets to the operation room, or access is anywhere? I just want to understand that. Thank you.
I think you can actually answer that question, Masika. Can you?
I can't. Okay, like, equity is when we all get equal opportunities, but access is, in my context, is when we have what should I say? Okay, we can access those opportunities from whatever locality we are in. I don't know. I stand to be corrected. Thank you.
So access to surgical care, the word access itself, maybe we'll learn about it in the later meetings, that access has various, or I'd say, departments. For example, an OR, we may have an OR, we may have the nurses. We may have the nurses around, we may have the surgical supplies, we may have everybody, and the patient is there, everything is safe. But on that day when the surgery is supposed to happen, the surgeon gets sick. So when the patient comes in the OR, do they have access? Of course, no, because they were not able to be performed to the surgery. So I would say that access starts from different bits. The workforce is there. We have the supplies. We have the OR itself. We have electricity, because without electricity, we cannot put a patient on the table. We have medications. So imagine operating on a patient and you have no antibiotic, either prophylaxis or the ones to give them. So it starts, as I said, like in the medical supplies, access equity, it starts when the products arrive at the hospital, because now we have the gloves. Imagine something as small as gloves wouldn't grant access if it wasn't there, because we cannot operate with our bare hands. So I would say access is just that complex compilation of all those small bits that will give the surgery to be performed. Thank you.
Thank you, Doctor, for the response. I see we're coming to the top of the hour, and like Doctor had earlier mentioned, she has another engagement, so we may not push on with the session any further. But at the end of the day, I really appreciate everyone for being part of today's call. And I really appreciate Doctor for the message you passed on to us. What I've been able to understand today is that we have to understand the gap between access and equity. And also we have to create empowerment and not looking down to ourselves at that we are either low. At the different levels we are in, we can still create impact through advocacy. We can use our voices in the different insurance rooms or any opportunity that we are given. And my take-home message of the day is you don't have to be a surgeon to talk about surgery.